The purpose of this film is to demonstrate the critical steps necessary to ensure that a surgical patient receives the correct surgical procedure. In this case, the patient has been transferred from the emergency department where he presented 6 hours earlier with intestinal obstruction. A flat plate of the abdomen showed multiple loops of distended small bowel. After decompression of the abdomen with nasogastric suction, rehydration with IV fluids, and potassium chloride replacement, the patient was prepared by the emergency medicine and surgical teams for an exploratory laparotomy, lysis of adhesions, and possible small bowel resection.
Good afternoon. I'm Rob Carducci. I'm one of the surgical nurses that's part of the surgical team that will be taking care of you today. Are you Noel Eldridge?
Yes.
Are your last four 2226?
Yep.
That was incorrect. Many adverse events due to patient misidentification have occurred when healthcare personnel have provided patients with identifying information and asked for their confirmation. Anxiety, distractions, cultural differences, and language barriers may interfere with a patient's understanding of questions asked of him or her just prior to undergoing a surgical procedure. Now let's see the correct way to identify a surgical patient.
Good afternoon. I'm Rob Carducci, one of the surgical nurses that's part of the operating room team that's going to be taking care of you today.
Hi.
Would you please state your name, social security number, and date of birth, please?
I went through all that in the emergency room. Don't you have some paperwork with my name on it?
Yes, I do, but we want you to identify yourself just to be absolutely certain. We sometimes have patients in here with very similar names. We don't want to perform a procedure on the wrong patient.
Has that actually happened?
Well, yes, it's happened in all the best hospitals in America. It's much safer for you to state your name and other identifying information to me yourself rather than for us to ask you to confirm what we say.
Okay, my name's Noel Eldridge. My birthday's April 10, 19...
Active patient identification is a critical element in patient safety for the prevention of patient misidentification in the operating room. This concept means that the patient, not healthcare personnel, takes an active role in his or her self-identification by stating full name, full social security number, or birth date.
Yes, Mr. Eldridge, that's all I need, and it matches what I have on our documentation in the computer and on your wristband. Now I'm reviewing your surgical consent form. Would you mind stating for me in your own words what operation you'll be undergoing today?
Well, the way Dr. Alba described it, my intestines are blocked up from my first operation in 1991.
Okay, so what is Dr. Albo planning to do?
He's going to go back into my guts and cut away the scar tissue adhesions, and he might have taken out part of my small intestines.
Okay, and did he say you might need a blood transfusion during this procedure?
Yeah.
Okay, Mr. Eldridge, do you have any questions?
Yeah, when is this going to happen?
We're setting up in the operating room right now. It shouldn't be much longer. Dr. Alba will be by to see you and to mark the surgical site.
Okay.
I'll see you in the OR in a few minutes, okay?
Okay, thanks.
Good afternoon, sir. I'm Dr. Shinek. I'll be your anesthesiologist today. Would you mind stating your name and your social security number, please?
My name's Noel Eldridge.
In greeting her
And, my
patient,
social security-
anesthesiologist Sal Shinak asked the patient to identify himself with his name and social security number or birth date. She verifies what he is saying with the information inscribed on his wristband. She will verify the patient's relevant medical history and the planned operative procedure. Sal also explains that the patient will need a nasogastric tube to empty the contents of his stomach before he goes to sleep, and she describes what he can expect when he is anesthetized and when he recovers from general anesthesia. After completing his own active patient identification, the surgeon Dan Albo greets the patient.
Hello again, Mr. Eldridge. Are you feeling any better since I last saw you in the ER a few hours ago? How is the pain?
I'm doing okay, Dr. Alba, but I'm getting worried about the time and my blocked intestines.
I understand. No worries. We'll be taking care of this shortly and you will be fine. I'm going to be marking the surgical site next where we're going to be placing our incision.
Marking the surgical site by the surgeon where the skin incision will be made is the third critical step to ensuring the correct surgical procedure. This task cannot be delegated to anyone but the operating surgeon to protect the safety of the surgical patient. The operating surgeon is the attending surgeon, the surgical resident, or the surgical fellow who will be starting the surgical procedure. It is essential that the marking pen used to mark the surgical site will leave a mark on the skin that cannot be removed when the surgical nurse subsequently preps the surgical site in the OR. The surgical site must also be marked in close proximity to the skin incision area so that it will be visible in the surgical field after prep and draping. It is important to remember for procedures that involve the right or left side of the body that only the side of the surgical procedure is marked. The side opposite the procedure should never be marked. Please note how the surgical site should be marked on some of the more challenging surgical procedures that have been associated with wrong site, wrong side, or wrong surgical procedures in the operating room or outside of the operating room. For surgical procedures involving sensitive areas of the body, such as the perineum, or for endoscopic procedures through the oral cavity or anus, or dental procedures, or transcutaneous procedures, a special purpose wristband can be applied instead of a skin marking. Such a wristband should indicate the planned procedure, including the surgical site and laterality, if the side of the body for the site is relevant. Knee arthroscopy, marking not on the thigh, but on the patella so the marking is visible in the surgical field. Hip replacement. Cataract extraction, marking not on the forehead, but just lateral to the lateral canthus of the eye to be visible in the surgical field. CT scan guided fine needle biopsy of the lung requiring a special purposed wristband. Radical nephrectomy, transurethral resection of the prostate requiring a special purposed wristband. Lumbar laminectomy, marking with the surgeon's initials at the skin incision site is followed by insertion of a spinal needle at the correct level while the patient is under local or general anesthesia. This is used as an anatomic reference guide during the surgical procedure. Dental extraction requiring special purposed wristband. Two professionals view the dental films together to identify the correct teeth for extraction. These teeth are checked off on a numerical dental map.
Okay, why don't you repeat that to me?
Yes, sir. 2,
Okay.
7.
Laparoscopic hemicolectomy, coronary artery bypass graft procedure. Both of these last two examples involve midline incisions. Midline incisions must always be marked to ensure the correct procedure will be conducted on the correct patient.
So how long will the operation take?
Oh, it should take a couple hours. It could be more. It really depends on how dense the scar tissue is inside your abdomen.
Okay, Doc, thanks.
No problem. I will see you in the OR shortly.
The surgical team has completed their preparation for the surgical procedure planned for our patient. The patient, Noel Eldridge, is being transported into the OR suite. In this case, Rob stayed with the patient after his patient identification in the pre-op holding area. If Rob was unable to stay with the patient, the active patient identification must be repeated by the surgical nurse who replaced him. That nurse would then accompany the patient to the OR suite.
Okay, Rob, let's go ahead and get the timeout done.
Right, I'll just run through our checklist, starting with our patient, Mr. Noel Eldridge.
I'm looking at his wristband. I have patient Noel Eldridge, Social Security 103-66-22226, date of birth April 10, 1960.
That's right. I have the procedure as exploratory laparotomy, lysis of adhesions, and possible small bowel resection.
The surgical site is marked with Dr. Albo's initials.
Okay, that's what I have on the IMED consent.
I can see that, Rob, and I confirm. I think we're good to go. Thank you.
Great.
The following critical steps must be included in the surgical timeout, with members of the surgical team confirming the following. 1. Accurate patient identity. 2. Accurate surgical consent with agreement of the entire surgical team on the planned procedure. 3. Correct positioning of the patient on the OR table. 4. If required for the procedure, 2 members of the surgical team view relevant images together to verify the images are available, correct, properly labeled, properly presented, and represent the correct patient.
These are Mr. Eldridge's films. Certainly looks like a small bowel obstruction.
I agree, David. Let's get it started then.
5. The correct implant if required. And 6. The correct surgical site is identified by a visible site marking after surgical prep and draping.